Welcome everybody. I'm Professor John Cam, and today I will guide you through the physiological mechanisms of angina and its treatment. Stable angina is a common and sometimes disabling disorder characterized by discomfort in the chest caused by myocardial ischemia. Angina is estimated to affect 20,000 to 40,000 individuals per million of the population in Europe. Angina attacks impair quality of life and increase the risk of mortality. Further, a proportion of patients treated with existing anti-anginal therapy continues to experience angina. The baseline clinical characteristics of stable angina patients reveal that 61% suffer from prior hypertension and 58% from hyperlipidemia. In normal conditions, the cycle of myocardial contraction and relaxation depends largely on the activity of the sodium channels within the cardiomyocytes. In the ischemic myocardium, sodium channels open normally, but many do not close completely, causing a pathological late leak in the late sodium current, which disrupts sodium and calcium homeostasis. The resulting calcium overload causes electrical dysfunction, mechanical dysfunction, and increased diastolic tension. Anti-ischemic pharmacological treatments are traditionally focused on optimizing myocardial oxygen supply and demand. For example, beta blockers lower heart rate, myocardial contractility, and blood pressure. Calcium channel blockers decrease afterload, while nitrates decrease preload. Finally, the IF inhibitor ivabradine slows the heart rate. Ranolazine is a new drug for the treatment of chronic stable angina that has a completely new mechanism of action. Ranolazine is considered as additional treatment for people whose angina symptoms are not adequately controlled by beta blockers or calcium channel blockers. By inhibiting the pathological late sodium current in ischemic cardiomyocytes, ranolazine can break the vicious cycle of myocardial angina and ischemia. Ranolazine selectively blocks the late sodium current in ischemic cardiomyocytes, reducing sodium overload and sodium-induced calcium overload. The resulting reduction in intracellular calcium improves diastolic relaxation, relieving compression in the microcirculation, helping to interrupt the vicious ischemic cycle. The anti-anginal and anti-ischemic effects of ranolazine do not depend on reduction in heart rate or blood pressure. This suggests that the beneficial mechanism of action of ranolazine is mostly due to an improvement in regional coronary blood flow in ischemic areas, without causing any adverse hemodynamic effect. The clinical efficacy of ranolazine has been proven in several studies. Marissa, Carissa, Roll, Erica, Merlin, Timmy 36, Teresa. Ranolazine significantly increased exercise duration and time to develop angina at both trough and peak levels of the drug. Ranolazine also improved the exercise tolerance test at 8 months in patients with acute coronary syndrome and a prior history of angina. Ranolazine significantly reduced the number of angina attacks already after 12 weeks, as shown by the Carissa study. These results have been confirmed even after 6 weeks in the ERICA trial. Finally, the Merlin-TIMI 36 trial among acute coronary syndrome patients with prior chronic angina confirmed the anti-anginal effect of ranolazine in a large number of patients. Additionally, patients treated with ranolazine needed to take less doses of nitroglycerine each week. The quality of life of patients treated with ranolazine was assessed in the ERICA and Merlin-TIMI 36 trials using the Seattle Angina Questionnaire. Both studies reported an improvement in quality of life and satisfaction for the treatment. In an open-label study of 20 patients with known or a high probability of coronary artery disease and angina, ranolazine treatment increased exercise time by 32 seconds, improved angina in 75% of patients, and reduced the size and severity of the perfusion defect in 70% of patients. A sub-analysis of Merlin-TIMI 36 in patients with acute coronary syndrome and stable angina who had PCI within 30 days showed that ranolazine reduced the primary endpoint, cardiovascular death, recurrent ischemia, and recurrent ischemia leading to revascularization. The efficacy of ranolazine has been studied in patients with type 2 diabetes, coronary artery disease, and chronic stable angina who remain symptomatic despite treatment with anti-anginal agents. The use of ranolazine for 8 weeks significantly reduced weekly sublingual nitroglycerine use as well as the weekly number of angina episodes. There was no difference in the incidence of serious adverse events between groups, while non-serious adverse events occurred more frequently with ranolazine. The most common adverse events in the ERICA trial were constipation, dizziness, nausea, peripheral edema, and headache. A retrospective case control analysis evaluated 4,545 angina patients who added or switched to ranolazine, nitrates, beta blockers, or calcium channel blockers for 6 months. The use of ranolazine in these patients was associated with lower rates of hospitalization and lower healthcare costs. Ranolazine should not be administered to patients with known hypersensitivity to its active ingredients or any excipient, severe renal impairment, or moderate to severe hepatic impairment. Furthermore, the concomitant use of ranolazine and potent CYP3A4 inhibitors or Class 1A or Class 3 antiarrhythmics other than amiodarone is contraindicated. Ranolazine in the European Union is available as 375 milligrams, 500 milligrams, and 750 milligram prolonged release tablets. The recommended initial dose of ranolazine is 375 milligrams twice daily. After 2 to 4 weeks, the dose should be titrated to 500 milligrams twice daily and further titrated to a recommended maximum dose of 750 milligrams twice daily. Down titration of ranolazine to 500 milligrams or 375 milligrams twice daily may be required if a patient experiences treatment-related adverse events. In summary, ranolazine is an add-on anti-anginal therapy to first-line strategies in patients with stable angina. It is an effective and well-tolerated anti-ischemic treatment with a neutral hemodynamic profile and innovative mechanism of action. Ranolazine improves myocardial flow reserve and perfusion. It is an effective and well-tolerated anti-ischemic treatment in patients with type 2 diabetes and chronic stable angina. Finally, ranolazine is associated with lower rates of hospitalizations, revascularization, and healthcare costs. Thank you for your attention.